Intestinal obstruction remains one of the most common surgical emergencies globally. In this 3D rendering, we can clearly see a section of dilated bowel pulsing against a mechanical stricture. The immediate clinical priority is distinguishing a true mechanical blockage, where a physical barrier stops flow, from an adynamic or functional ileus. While making that distinction, clinicians must check for signs of strangulation or bowel ischemia. Continuous, localized, and rigid abdominal pain serves as an immediate clinical red flag for tissue necrosis. The underlying cause, the bedside presentation, and the radiological signature of a blockage are dictated by its anatomical location. Mapping the obstruction's exact geography allows surgical teams to intervene before tissue death becomes irreversible. Moving to the proximal GI tract, the small bowel accounts for 80% of obstruction cases. As shown here in this model, fluid forcefully backs up into the stomach as the duodenum and jejunum dilate. In developed nations, postoperative adhesions are the primary cause of small bowel obstruction, responsible for about 60% of cases. Global data shows that incarcerated hernias remain a leading cause, particularly in developing regions. Clinicians must palpate the groin areas for these hernias during the physical exam, as they are a vital but frequently missed bedside sign. Patients typically present with colicky abdominal pain, paroxysmal, cramping waves that coincide with peristaltic rushes as the gut attempts to overcome the block. Vomiting occurs early and is often profuse, consisting of bilious or gastric contents. Because the blockage is high in the GI tract, abdominal distension remains minimal. This diagram represents a small bowel radiograph. Erect and supine films reveal dilated bowel loops and multiple air fluid levels, forming a distinct stepladder pattern. These lines, the valvulae conniventes, cross the entire width of the small intestine, serving as a unique anatomical marker. Proximal blockages create dramatic upper GI symptoms early on, while leaving a small physical footprint. Looking lower at the colon, we see the mechanics of large bowel obstruction. Here, gas and fluid accumulate behind a mass, slowly occluding the lumen. Colorectal carcinoma is the dominant cause, responsible for over 60% of adult large bowel obstructions. Secondary causes include sigmoid or cecal volvulus and fibrotic strictures caused by chronic diverticulitis. Large bowel obstructions follow a slower, more progressive timeline than small bowel obstructions. Profound, generalized abdominal distension serves as the cardinal physical sign for these distal blocks. Absolute constipation, or obstipation, is the inability to pass both feces and flatus. Early on, patients may still pass residual gas, which can mask the severity of the obstruction. Vomiting is a very late sign. Here, retrograde bacterial overgrowth causes the vomitus to become feculent. Comparing the radiological markers of the large and small bowel shows how to differentiate the two. The large bowel displays peripheral haustra. Unlike the small bowel markers, these lines do not cross the entire width of the lumen. These obstructions develop slowly and can hide deep pathologies like malignancy behind massive physical distension. While X-rays provide rapid triage, contrast-enhanced CT of the abdomen and pelvis is the diagnostic standard. The CT identifies the exact transition zone, the point where dilated loops of bowel instantly become collapsed. Pinpointing this zone allows clinicians to identify the specific cause of the obstruction, such as an adhesive band or a tumor. Beyond localization, the scan serves a life-saving secondary function, detecting early signs of strangulation. Radiographic markers of ischemia include poor wall enhancement and the presence of mesenteric edema. Pneumatosis intestinalis, or gas within the bowel wall, is a critical red flag for severe necrosis. Contrast-enhanced imaging moves focus beyond the block to the exact location of the necrotic gret. All obstructions require immediate resuscitation and fluid replacement using isotonic crystalloids. This protocol focuses on correcting electrolyte imbalances caused by vomiting, specifically hypokalemia and hypochloremic metabolic alkalosis. To decompress the stomach and proximal bowel, clinicians insert a wide-bore nasogastric tube, which reduces the risk of aspiration. A Foley catheter is necessary to track hourly urine output, ensuring it remains above 0.5 milliliters per kilogram per hour. The historical surgical axiom, "never let the sun rise or set on a mechanical bowel obstruction," has evolved alongside modern imaging. Many partial obstructions, particularly adhesive small bowel obstructions, can be initially managed conservatively for 48 to 72 hours. Urgent laparotomy is indicated if the patient shows signs of peritonitis, a closed-loop obstruction on CT, or fails to improve within the observation window. Modern management relies on the calculated balance of aggressive physiological stabilization and precise anatomical intelligence.